Right, it's 2 o'clock, so I'll just do some quick introductions. My name's Sam. I'm one of the tissue viability nurses for Coloplast, and I'm joined by my colleague Kirsty, who's also a tissue viability nurse. I'm sure she's going to introduce herself in a minute. And thank you so much for coming to join us this afternoon for our Making Life Easier Antimicrobial Stewardship in Wound Care. If you have any questions, please pop them in the chat. I'll be looking at the chat. I'll try and answer as much as possible. And then if we have time at the end, we can always have some further discussions and questions. But I shall hand over to Kirsty.
So as Sam said, my name is Kirsty and I'm one of the tissue viability nurses at Coloplast. I've been with Coloplast 3 years now and I've been a tissue viability nurse for 10. And as Sam said, we are here today for the Making Life Easier Antimicrobial Stewardship in Wound Care webinar. Normally we have a couple of minutes to allow any latecomers to join, but it is quite a big webinar to get through, so we will just get started. As Sam said, any questions just pop in the chat and we'll try and cover any at the end as well. So the objectives of today's session is we will introduce you to the 3-step approach by Coloplast, which is a step-by-step framework that allows you to effectively assess, prepare and treat wounds. But what we'll do is throughout the session, we'll relate that back to antimicrobial stewardship and wound infection. So you'll learn a simplified approach to wound healing, understand the impact that wound infection and biofilm can have on antimicrobial resistance and antimicrobial stewardship, as well as wound care in general. You'll gain an overview of the latest best practice from the International Wound Infection Institute and the importance of why we need to practice antimicrobial stewardship. And you will leave with the 3-step approach antimicrobial stewardship pathway to help you support your practice and your assessment, your wound preparation, and your treatment as well. So as we know, the wound care landscape is challenging. There is no one demographic that gets a wound. Everybody can unfortunately suffer with a wound. The workload for nurses is increasing. However, our workforce is decreasing. There is no set funding for wound care either. There's no sequin target or incentive or anything like that. There is some things for leg ulcers in community settings, but all in all, the funding's a bit sparse when it comes to wound care. And we do know from the Julian Guest data that was published in 2017-2018 that only 6% of what you think is being spent on wound care is actually the products themselves. It's all down to the other factors as well. And we know that the patient setting in order to conduct wound care is changing as well. There's more of a push for it to be done closer to home in the community, which adds additional challenges and pressures as well. There is a considerable amount of resources that go into managing wounds, and what you can see on the slide in front of you and on the graphs is how them resources have changed over the years. So the light turquoise is data from 2012, 2013, and the darker column is from 2017, 2018, and you can see the considerable increase in where them resources are being placed across the care setting. So you can see a massive jump into district and community nursing resources, as well as more healthcare assistants are being utilised to do wound care as well. And this is data that goes back like 8-9 years, so we can assume that will have changed and then will have jumped again. From that Julian Guest data that I just mentioned, we know that 3.8 million patients are managed annually with a wound, and the annual cost of managing wounds that were healed was estimated to be about 2.7 billion compared to 5.6 billion for the 30% of wounds that didn't heal. Now it's estimated that 60% of chronic wounds heal if there's no evidence of infection, compared with the 45% if there's been a definitive or suspected infection. So it's quite a big jump. There is a prevalence of 80% of wounds that will have a biofilm present in them. And as we go through the session today, we'll understand how that makes it more difficult for wounds to heal. And in some data that's held on file from 2017, 46% of healthcare professionals believe that infection is a challenge when it comes to treating wounds. And I'm sure it's something that you have all struggled with in your practices as well. We all know that one, two, or a handful of patients that have had and suffered with wound infections that make it really difficult to manage and treat them wounds and get them on a healing trajectory. Infection is common and is a common wound complication. Like I said, all of us will have dealt with a patient and wounds with wound infections, and it can be often difficult to identify. All wounds are contaminated with microorganisms, and that's because we have our own bacteria and skin flora that's just on the surface of our skin anyway. So as soon as we've got a wound, obviously that skin flora and the microorganisms that are on our surface of our skin are going to go into the wound and infiltrate it. However, what happens with wound infection, and it becomes then microorganisms become a wound infection when they move deeper into the wound and start proliferating and multiplying, and it's kind of a tipping point on what your body can manage and whether the scales are tipped. How our body and how the host immune system and the species of the bugs and the microorganisms that get into the wound can also influence the development of that wound infection. If a wound does become infected, we know that wound healing is delayed. A patient's quality of life can be adversely impacted, and that could be resulted from what they're experiencing from the wound in regards to pain, exudate levels, malodor, but also it could be things like the need for more appointments, more dressing changes, and obviously they're living longer with a wound. Treatment costs can rise, and that's down to the products that are being used, but also the clinician's time. Like I said, they will probably need more dressing changes and more complex dressing changes as well. And it's really essential that we get on top of things and have a holistic approach, a proper assessment and early intervention so that these problems can be avoided and the clinical outcomes can be improved. Now, today's session is on antimicrobial stewardship in wound care, but what comes with antimicrobial stewardship is antimicrobial resistance. And antimicrobial resistance is a natural process that happens over time, and it occurs when bacteria, viruses, fungi and parasites no longer respond to antimicrobial medicine, and that can be down to misuse and overuse of antibiotics, so not getting them and when we're supposed to and when we actually need them. Or also it can be also down to not finishing a course of antibiotics. So if you've been given a 7-day course of antibiotics, if you start feeling better on day 4 and stop taking them, that can also lead to antimicrobial resistance as well. It can also occur due to poor infection control practices as well, if we're not on top of our clean and aseptic techniques. And there's also a lack of new antimicrobials being developed to combat the bugs that are in and the microorganisms that are in the wounds. I think the last time I looked, the last new antimicrobial like trailblazer antimicrobial that had been developed hadn't been done since the late 80s, early 90s. So it's quite a significant jump. So even though we're getting new vaccines and things like that, actual antimicrobials are taking a little bit longer. So through the slide deck, you will see antimicrobial resistance shortened down to AMR, and that's what you'll see going forward. So antimicrobial resistance is one of the top 10 global public health threats, and it is listed on the UK's risk register. In 2019, it was estimated that AMR was responsible for 1.27 million global deaths. So obviously this was pre-pandemic as well. So again, we can assume that that's even higher. It also continues to increase as more people are suffering with prolonged infections, therefore increasing their hospital stays as well, which again, we'll come on to it, makes them more susceptible at the risk of getting infection. And in some work and in a publication done in 2016, it was estimated that by 2050, 10 million people will die every year because of antimicrobial resistance unless we do something about it globally. So again, this was 4 years pre-pandemic, when everyone's attitudes and things change towards infection and spreading of infection and things like that. So again, that number is probably could be higher now as well. So when it comes to antimicrobial resistance and wound care practices, when it comes to wound care, because of antimicrobial resistance, topical antimicrobials such as your silvers, your honeys, things like that are being used more increasingly. And what we need to do to combat this, and the approach we need to have, is something called antimicrobial stewardship, or AMS. And it's important that in order to do AMS correctly, is that it's a multidisciplinary approach, and we need to have everybody on board in order to combat it. It is critical that our practices minimise the possibility of microorganisms developing resistance that would then lead to the antimicrobial resistance. And to do that, we need to do it through educating our patients and also our colleagues and healthcare professionals. We change traditional practices and processes, and also challenge them as well. If you see in practices that you think are contributing to this global threat, then do something about it and step up. It's important that we have an accurate assessment to know if a wound is infected, not infected, or at risk of getting infected. It's also critical that we utilise proper preparation and treatment options with a physical mode of action, which will help that as well, and also create an increased awareness in regards to all this. And actually, tomorrow is International International Infection Day, so there is awareness globally as well. So as I said, at Coloplast, we have a simplified framework for help you in managing your wounds, and that is our 3-step approach. So that consists of step 1 is wound assessment. So this is a holistic and wound assessment, which is paramount in defining your treatment objectives. Step 2 is your wound preparation, which is key to removing the barriers to healing and also helping create that optimum healing environment. And on to step 3, which is where you would use a simplified portfolio of dressings to manage a wound any depth and any stage of healing. And like I said earlier, what we'll do is we'll break down each section of the Coloplast 3-step approach, utilising our antimicrobial stewardship pathway, and cover antimicrobial stewardship and wound infection at each stage. So this is just a snapshot of what our assessment section looks like on the antimicrobial stewardship pathway. And when we're looking at doing our wound assessment, the aims that we need to try and get to the bottom of is we really need to identify the cause of that skin breakdown and correct and treat the underlying cause, because that is essential. We need to know what we're dealing with in order to give us the right treatment objectives. You treat a pressure ulcer completely different to a moisture lesion, and you treat a venous leg ulcer different to an arterial leg ulcer. So we really need to get to the bottom of that, because it's really going to help with our treatment at the other end. We also need to identify any associated risk factors to make sure we're covering all angles and giving the best to our patients. Identify the appropriate treatment and management options for our patients as well, because not one size fits all. What might have worked really well on a patient you saw last week won't be the same for the patient that you're seeing tomorrow. We also need to control them wound-related symptoms. So if you're assessing your wound and you can see it's really high in exudate, it's really important that your treatment objective is to manage that and to get control of that, because, and as we'll come to in slides, if we don't get on top of exudate, it can cause the wound to break down further. It can cause issues to the wound edge and the peri-wound skin as well, which will then make your wound even bigger. The other thing we need to do is also identify the patient's expectations. When I was working clinically a few years ago whilst at Coloplast, I had a patient that came to see me that was changing his dressings twice a day, and he'd had his wound since 2002. He never expected his wound to heal, but his expectation was to go even just down to daily dressings rather than twice daily dressings. So it's important to identify them patient expectations and be aligned so that, you know, they don't get disheartened. You can keep with that therapeutic relationship, and they're going to comply with their care as well. And luckily enough, that patient did go down to actually twice weekly dressings, luckily. So but their expectation, he just wanted to go to daily, so we succeeded his expectations anyways. You also want to provide psychosocial support and promote patient independence and some form of supported self-management that can really help with their quality of life. And it's really important to provide psychosocial support, especially with patients that have had wounds that are quite chronic and are hard to heal, and they've had them for a long time, because it really could be impacting their quality of life and also their mental health. When we're looking at assessing wounds, different wound, like your acute wounds and your chronic wounds, can have different risk factors that might tip that scale into a wound infection. So when it comes to your acute wounds, it's your contaminated and dirty wounds that are more predisposed to infection. Any operative procedure, so even though they're in a sterile environment, you're still causing a break in the skin. And like I said earlier, our skin does have microorganisms that live on it and have our own skin flora. So you're still creating a wound that's gonna potentially cause make them predisposed. If there's any trauma with any delayed treatment because you're not cleaning the wound, anything could be in there causing an infection and getting deeper into the wound. If they've got a pre-existing infection anywhere, so as we'll get onto when we get to the continuum, and as I said, it's your host response on how a wound infection comes about anyway. And if you've already got a pre-existing infection, whether or not it's a chest infection, a throat infection, anything like that, your body's already fighting one type of microorganism and one infection. So if you then get a wound infection, it might just tip the scales. Any spillage from your GI tract, again, because of the contaminated matter that's there, and inappropriate hair removal as well, again, because it could cause breaks in the skin or anything like that. Then when it gets to your chronic wounds, the older the wound, the more likelihood there is of an infection and more chance there is that there's a biofilm present. The bigger and deeper the wound is as well can make the wound more predisposed to infection. And if it's anatomically near a potential contamination site, so if you think of your pinoidal sinuses and sacral pressure sores and things like that. Then there's characteristics which can predispose both acute and chronic wounds to infection, and that's your necrotic and sloughy tissue, because it's a breeding ground for microorganisms. Impaired tissue perfusion, because you're not getting that circulation. Hematoma, because again, you've got a breeding ground for bugs to kind of start harbouring and making friends. Inappropriately managed exudate or edema. Wounds also that involve underlying structure or over a bony prominence as well, and they're really at risk of osteomyelitis. So we've covered factors that might predispose a wound to an infection, but what about the person themselves? And unfortunately, everyone is at risk of getting a wound infection. And as I've said, the development of a wound infection is multifactorial and occurs when all these risk factors overwhelm the host defense system. So it's when them scales are tipped and our body just can't fight them off anymore. Factors that deliberate the patient, impair their immune response, or reduce tissue perfusion increase the risk of infection. And these risks can be split into individual factors, but also the environment that we find ourselves in. So when we get to our individual factors, these can cover things like poorly controlled diabetes, any prior surgery, certain medications, especially steroids, or anything that's compromising your immune system, conditions that are associated with hypoxia or poor tissue perfusion, immune system disorders, because our body's just not in that right state to be able to fight it in the first place, inappropriate antibiotic prophylaxis, if you've got a protein energy malnutrition, and alcohol, smoking and drug abuse as well. And in order to try and combat them, we really need to make sure we've got an optimal host response. So this is about the individual. So we really want to manage them comorbidities, make sure their diabetes is as effective as it can be, their blood sugars, and or if they're taking insulin or if they're doing it properly. We also want to optimize nutritional status and hydration, so making sure they're getting the right levels of protein in their body, as well as being having the right water as well. If they have got another infection, we need to seek and treat it and make sure they're on the right treatment for that infection. Provide a systemic antimicrobial or antibiotic if necessary. We also want to get on top of their pain and fever if they are in any, because then that can obviously again change if they're fighting off pain and things, then it can also change the way their body is going to affect to an infection. We also need to educate the patient or their carer or their loved one or whoever it is that's doing the wound care about the wound and why we're doing what we're doing and the importance of doing what we're doing. So why you need to prepare a wound and clean it, why you need the thorough assessment, and just tell them what you're doing and get them on board. And again, we need to ensure that psychosocial support to ensure they're cooperating, and then eliminate or minimise any other risk factors that you've identified in your assessment. So then it comes to the environmental factors. So that can be things like hospitalisation. So even though hospitals are really clean and you see the cleaners and they're cleaning them regularly, it still is there's poorly people there. They've still got all these bugs and there's a chance of cross-contamination. If they live in an unhygienic environment as well, that can all increase the risks. If they have poor personal hygiene or there is poor hygiene and aseptic technique in regards to their wounds, it's going to cause that cross-contamination. We've all, as clinicians, heard the story of a district nurse going in to do a leg ulcer and clean the leg ulcer, and the dog comes over and licks it. Obviously, that's going to increase the risk of a wound infection. Also, inadequate pressure offloading. If you're changing the dressing unnecessarily or increasing the dressing changes, and again, that inadequate management of moisture, exudate and edema. And the things that we can do to combat this is provide a wound care in a clean environment, do appropriate aseptic technique based on your risk assessment of not only the patient, the wound, but also the environment as well. Again, it's about educating that patient, carer, loved one on what you were doing, reviewing your own policies and procedures as well in your workplace to see if they're up to standard with the recent changes that have been in international guidance, and storing your equipment appropriately to make sure that it's still within the manufacturing guidance. And by doing a wound assessment, that early identification and treatment can help reduce the risk of a wound tipping into an infection. It is clinically but also economically beneficial to facilitate the wound healing. It can reduce the impact on the patient and also the healthcare system as well. But if we have a holistic and collaborative approach, it is in best practice and also in the best interest of the patient and will improve their quality of life. It also will have effects on them as a person as well. Like I say, it'll help their quality of life. So doing a comprehensive wound infection prevention and treatment plan, it should address optimising the individual's host response, reducing that local bioburden and promoting a positive environment for wound healing. One framework that could help you in simplifying that wound assessment, because we know it can be challenging when you've got to think of everything going on in the wound as well as the whole patient, is the triangle of wound assessment. And this is a concept that looks at the wound into three key areas. So that's the wound bed, the wound edge and the peri-wound skin, and then you'd base your treatment objective over using them all. So for the wound bed, you'd be looking at the tissue types that are there, exudate levels, and obviously any risk of infection. And then for your wound edge, you'd be looking at maceration, any dehydration, and again, peri-wound skin, you'd be looking at maceration, excoriation, and that should give you a really rounded treatment objective. So as I said, all wounds can be contaminated with microorganisms. Wound infection occurs when the microorganisms move deeper into the wound and start proliferating and breeding and branching out. And again, it's that tipping scale for our host immune system and also the types of microorganisms that have got into the wound. So this is the National Institute of Wound Infections infection continuum. And as you can see on the screen, it's split into 5 sections. And then the blue triangle is the increase in microorganisms that are in the wound bed at any stage. As you can see, it moves from contamination through to systemic infection, and the amount of microorganisms in the wound get bigger and bigger and bigger. And what we'll do now is we'll spend a couple of slides just going over the stages. So the first stage is contamination. So this is all wounds are contaminated. This is what we've said. in a contaminated wound, your body is able to fight off the microorganisms. There's no clinical signs or symptoms of infection, and your body is able to heal the wound quite nicely with minimal intervention. Then we get on to the colonization stage. So as you can see, the triangle's slightly widening, and there is a little bit of spreading, a little bit of proliferation, but there's no host response yet. So your body is still able to fight off the bacteria and the microorganisms that are there. So they are starting to grow, but they're not at a critical level. They're not damaging the wound, and at this point, there is no significant effect on wound healing. However, at this point, we need to start being mindful and looking for the signs and symptoms of a biofilm in order to act early and stop the wound from tipping into a wound infection. Then we've got the third stage, which is the local infection. So this is where they have moved deeper into the wound bed, and they're now starting to cause a response in your body and in the wound. The response is localized to in regards to wound infection. It's localized to just the wound, and there may be subtle signs, but your classic wound infection signs might be starting to show. So you might be seeing redness and erythema around the wound. You might start to feel a bit hot around the wound as well. The wound might have been looking okay and on a healing trajectory when you saw it last, but it's now starting to break down. There might be increased exudate, and they might start to be experiencing some pain, or the tissue might be starting to bleed when you're doing wound preparation, and there might be an odour as well. So on to the spreading infection. So the microorganisms are present in the wound, and they're now starting to invade the surrounding tissues as well. So here you'll see all the signs and symptoms of infection, but you might see early indicators of a systemic infection as well. So the patient now might now start to say that they're feeling unwell from it. And then you've got your systemic infection. So this is the fifth stage, and this is basically you're looking out for the signs and symptoms of sepsis. So it's not just in the wound now, it's gone into the lymphatic or the vascular system and spread throughout the body as well. So there's a proper host response now to the wound infection. And as I said, over from colonization, you need to be mindful of biofilm formation so that they can be treated appropriately. And a biofilm is a structured community of microorganisms with genetic diversity that create chronic infection. They're categorized by their significant tolerance to antibiotics and antimicrobials while remaining protected from the host response. So it's like a shield that goes over the wound that stops anything from penetrating it. And it makes it really difficult for the products to be able to take effect on the wound and treat the wound. And the biofilms are naked to and invisible to the eye, but your signs and symptoms of a local infection would indicate biofilm. So your delayed wound healing, increased exudate, erythema, malodor, and a high bacterial load. And what biofilms do is they keep the wound in that inflammatory state. So you've got a non-healing wound, which is perfect environment and breeding ground for a biofilm formation. That then biofilm then causes an inflammatory response. The inflammatory response causes a delay and delayed wound healing and tissue damage, which again is the ideal environment. So it's a constant cycle, and something needs to go in and break that cycle. So there are complications when it comes to wound infection, and wound infection is a common complication, but there's other things that we can have things like necrotizing fasciitis, osteomyelitis, and sepsis as well, which could cause even more problems for the patient. And like I said before, sepsis is one of the things you need to be aware of. It's a life-threatening complication, and it's because of the presence of their microorganisms in the blood. For sepsis, you need to be looking out for excessive pain, confusion, disorientation, shortness of breath, shivering, fever, or a very cold temperature. It could be one or the other. A high heart rate, clamminess, and as well as your localized signs of infection. And then you also want to be looking out for things like, have they got diarrhea, a sore throat, respiratory systems? Like I said, it's affecting the host as a whole now. If you do suspect sepsis, it's 999 to A&E for rapid investigations, blood cultures, and systemic antimicrobial antibiotics to start straight away with some fluids. So to know that a wound is infected, you need to sometimes obviously we can look at it and see just from obviously the local site of infection, but there are cases where you might need to do a sample. And the general rule of thumb for when you need to take a microbiological analysis is if you've got an acute wound that has classic symptoms of infection. Any chronic wounds that have signs of spreading or systemic infection, you wouldn't necessarily swab if they had signs of a local infection. If you've got an infected wound that's failed to respond to antimicrobial treatment or it's getting worse, if your local protocol says different, so there might be some areas that might be doing surveillance for something, so they might want it to be done sooner. So always check your local policies and protocols. And if there's certain microorganisms that would stop a surgical procedure, so certain things would stop skin grafting. So there are some principles around antimicrobial stewardship that's going to help kind of put these measures in place. And in the best practice document by Wounds UK, they said there was 5 rights of antimicrobial stewardship, and they're the right diagnosis and care plan, the right antimicrobial and delivery system, the right time to initiate, the right antimicrobial dose, and the right duration. And to simplify that down at Coloplast, what that means for us is appropriate education on the principles of AMS and AMR, and also on appropriate assessment and treatment. When it comes to appropriate product choice, we're looking, when we're at the 3-step approach, into wound prepare and treat. So you want to prepare the wound to remove devitalized tissue and help reduce that bioburden. And it also helps, by doing wound preparation, it helps the antimicrobials reach the targeted areas. And then you've got a treatment choice that has an active mode of delivery by sequestering microorganisms. And then for appropriate duration, you've got your 2-week challenge, and we'll cover all this more in depth. So that is step 1, assessment of the 3-step approach for antimicrobial stewardship. So now we'll move on to prepare. So slough, non-viable tissue and biofilms can all delay wound healing as they can increase the risk of infection, inhibit the development of healthy tissue, but they can also limit your wound assessment. There's times when we've gone to assess wounds and looked at a wound and it's been 100% covered in slough, but once we've started to do wound preparation and the slough started to come away, we can see some actual granulation tissue in there, and that changes our treatment objectives as well. It has been clinically proven that cleansing and debridement can speed up wound healing, and the graph that you've got on your screen in front of you is a snapshot from the Wilcox study that was done in 2013 that showed that if you debrided a wound once every 2 weeks, that had an average healing time of 76 days. But by adding an extra debridement session in, so it went from once every 2 weeks, to once a week, the healing time reduced to 21 days. So it is clinically proven to speed up wound healing. This is also from the best practice recommendations on wound preparation, and it just identifies the different types of wound preparation that can be done, down from washing, cleansing and down to surgical and sharp debridement. So your washing and cleansing anyone can do. Then you've got your debridement methods such as autolytic, mechanical, biological and enzymatic, which don't require an extended competency, but you do need to know about the products that you use and if there's any skills that you need. And then you've got your surgical and sharp debridement, which does require an extended skill and competency and should refer if you feel like you need that. Wound preparation is also in the international best practice for the management of biofilms and infection, and it is step 1. It's what they say that you should do as one of the many treatment strategies. And it's step 1 is wound preparation. You need to cleanse and debride to reduce the microorganisms by disturbing and removing some of that biofilms. And then step 2 and 3 are your dressing choice after that. So step 1 is wound preparation. And when we're talking about the 5 rights, this is your appropriate product choice. So this is you preparing the wound, removing the devitalized tissue, reducing that bioburden, allowing the antimicrobials to get to them target areas more effectively, It's allowing for better infection control and the development of healthy tissue. So it's really feeding into antimicrobial stewardship. Wounds should be prepared. There's a bit of a debate on how often they should be prepared. As a clinician that's done wound preparation all the time, I would say every dressing change possible. It does facilitate and accelerate healing and the effectiveness of that management and treatment plan. But however, it is based on your wound assessment, your clinical judgment, and the patient's pain levels as well. But regardless, it should be regular. The more frequent the debridement sessions, the better the healing. So it is important to take that in bear that in mind. There are times when you need to be cautious with wound preparation, and that's if a patient has a wound on the lower limb and is known to be diabetic, if they've got a known arterial flow concern or poor localized tissue perfusion, if their healing ability is impaired because of certain medications, or if you think the wound could be malignant as well. That's another one where you would err on the side of caution with wound preparation and get some more advice and another opinion. So that's step 2, and that's preparing a wound that's infected or has a biofilm. So what we'll do now is we'll move on to treat, and this treatment section is based on if a wound was infected or had a biofilm. So when you've done your wound assessment, you would identify your treatment objectives, and that could be down to exudate or exudate pooling, protection of the peri-wound skin, maceration or excoriation, managing the depth or the cavity that's in the wound, or infection biofilm management, or it could be all of these. And this is why it's important to do your triangle of wound assessment and do your holistic assessment so you can identify these. What is beneficial to keep in mind is when a dressing doesn't fit to the wound bed properly, a gap can form underneath it. So with your conventional foam dressings, a gap can form between the wound bed and the dressing. And what happens there is it allows for exudate to pool into the wound bed. And then what happens is it's like a cup overflowing when you leave a tap on. It fills up and then flows over the edge. So then it'll affect your wound bed and your peri-wound skin. So it will cause risk of infection because you've got a breeding ground for that bacteria and those microorganisms, but it can break down the wound as well because the exudate, it'll just break down the wound and make it bigger. And it does cause a challenge for patients because the skin in a short period of time can become significantly damaged. And you can see that with wounds like pressure ulcers, which can develop quite quickly, but it can also be due to wound exudate as well. And it can delay wound healing, cause infection, and affect your patient's quality of life as well. 96% of healthcare professionals agree that effective management of wound exudate is one of the best ways to promote an optimal healing environment. And like I said, all wounds have a gap, no matter what their depth is. Even if you've got it because of the contours of our body and everything like that, every wound has a gap. And like I said, 96% of healthcare professionals agree that effective exudate management is one way to promote optimal healing. 89% of healthcare professionals agree that managing the gap is important when an effective way of managing wound healing, and 83% agree that a best dressing choice is a wound that conforms up to 2 centimeters deep. The international best practice guidance for the management of biofilms and infections obviously said step 1 is wound preparation, but they said it's not a one-step solution. You also then need to think about your dressing choice. So you want a barrier dressing, you want one that's going to prevent maceration by managing that exudate and also prevent recontamination. And you also want that's going to, if you have got a wound that's got an infection or a biofilm, you want one that's going to suppress that biofilm from forming back. So you want something like your biotin silicone that retains 99.98% of bacteria. It's also providing a barrier dressing because it's conforming to the wound bed, stopping that exudate from pooling. But because it's retaining the bacteria, it's preventing that recontamination. But if you've got a silver dressing in there, which we'll come to in a second, it's also going to suppress that biofilm formation and stop that biofilm from growing back because of the active agent in the silver. There are different topical antimicrobial treatment options. You've got your antiseptics, which is your silver and your PHMB. And then you've got your things like your antibiotics, like your metronidazole gel. So your silvers and your PHMBs are disruptive and do have a biocidal effect on bacteria. They have multiple sites of antimicrobial action and are at low risk of bacterial resistance. So when we're talking about antimicrobial stewardship and antimicrobial resistance, these are at low risk of developing that resistance. However, they are non-selective and certain products can cause skin and tissue damage if they're not delivered to the wound bed in a sustained release manner. So if they just dump the antimicrobial agent into the wound, it can have an effect on the wound, and they're recommended for localized wound infection. The main types of antimicrobials that you will see are your honeys, your PHMBs. Some places may still see iodine, it might be on specialist use, and then your silver are the ones that you see. Antimicrobials you can find in all forms. You can find them in liquids, paste, creams, ointments, sprays, impregnate dressings, you name it, there will be an antimicrobial in that form. And depending on the type of antimicrobial that you're using, and each different product will have different ways that it's supposed to be applicated and used, and how often it's supposed to be used for. What we'll do over the next couple of slides, so we'll focus on silver. And silver is a topical agent, and it's been used for thousands of years in wound care to prevent and treat infection. And recently, over the last 20 years, it's been developed into a variety of different wound dressings to make them that they're easier to apply and provide that sustained release. So silver works by being toxic to bacteria and certain fungi and certain viruses. And if you go back to your GCSE science lessons, the ion has to be positively charged to have that antimicrobial effect. So going and putting a silver spoon out the cutlery drawer on is not going to do anything. It does need to be positively charged. It has multiple ways in which it kills bacteria. So it can bind to the bacterial cell wall, blocking the transport of substances in and out of the cell. So blocking its trade routes, basically. It also can block the respiratory system and destroy its energy production. So basically stopping it from breathing. And then it can also affect with its DNA to stop it replicating. So there's many ways in which it can stop bacteria from reforming. Now, if we go back to the wound care continuum, when would we implement an antimicrobial to give it the best use and also keep in line with antimicrobial stewardship? So as we said, there's no signs of an infection, there's no host response when we're looking at a contaminated kind of colonizing wound. So we wouldn't need to do anything here. There isn't an antimicrobial that's required. When it comes to your local infections, or if you believe a biofilm might be forming, an antimicrobial dressing would be indicated here. So this is where you would use one. So if you're starting to see the early signs of a wound infection, that's where you would use utilize your antimicrobial. When you get to your spreading infection and your systemic infection, this is where you're needing antibiotics, but also you would continue to use your antimicrobial dressing as well. You'd hit it from both sides. There is something called the 2-week challenge that some of you might not be aware of. So this is where you would use an antimicrobial for a duration of 2 weeks to make sure that it's being used appropriately. So we'd use the antimicrobial, so say for the silver, for example, for 2 weeks. After 2 weeks, you would repeat your assessment. So if you saw improvement, but it was still seeing signs of infection, you continue with your treatment with regular reviews. If you saw improvement and no signs of infection, you'd stop using the silver and step down to your conventional dressing. If there was no improvement, the silver should be discontinued and you would use a different antimicrobial agent. And depending on what was happening with the wound, you might want to look at a wound swab or a systematic antibiotic as well. And this feeds into the antimicrobial stewardship rights with the appropriate duration. So you're giving the antimicrobial the right length of time to see if it's going to work to give it that effect on the wound. So when we talked about wound preparation previously and treatment, we looked at wounds that had an infection or a biofilm. However, there are wounds that are at risk of getting an infection. So when it comes to preparing these wounds, it's appropriate that we do it and manage it to reduce the likelihood of that wound infection happening. By doing that, we're removing any barriers to delaying healing and reducing that risk. And we're also preventing that formation of a biofilm. Wound preparation does reduce that bacterial burden. It prevents them microorganisms from multiplying and proliferating and moving deeper, because you're getting rid of it off the wound. You're removing it from the wound bed, and it's going on to, from the picture that's in front of me, you're going onto the all prep pad and removing it from the wound bed. And then this is where, again, it's your appropriate choice and your appropriate education, which are coming in here with your 5 rights. So you're using your appropriate product choice through your wound preparation, but because of your appropriate education, you've understood the need that you need to keep on top of it. When it comes to treating wounds that are at risk of infection, obviously it's when to implement an antimicrobial, and this is where sometimes it can come a little bit of a grey area, because you've got the colonization stage where you might start seeing signs of infection. So you really need to be clear. The wound needs to be at risk in order to implement it here. But if you're using a product like biotin silicon, which, like I've said, retains 99.9% of bacteria and has that physical mode of action, already on the trajectory of trying to prevent that wound from tipping and implementing. However, if you have real concerns, then obviously reach out and speak to get a second opinion on whether or not you need to use an antimicrobial. Like I've said, it's important that we still continue with wound preparation to minimise the risk of infection, and it also you have a dressing that absorbs and retains the bacteria. So these points are from various international literature that supports the dressing, to use a dressing that supports a positive antimicrobial stewardship. So you want a dressing that has a physical, non-medicated mode of action and supports wound bioburden management without the risk of the wound developing bacterial resistance. There may be some cases, however, where you need to use prophylactic use of antimicrobials in wounds or in an individual that is at high risk of infection. And that comes by following a full holistic and wound assessment. So you'd assess the wound and the patient, and if you deem them high risk of developing a wound infection, cautious use of a topical antimicrobial treatment may be appropriate. So I had a patient when I had my clinics who was they'd had their wound for over a decade. They were quite chaotic in their approach to wound care. They had a quite chaotic lifestyle. They were an intravenous drug user. For me, that needed the prophylactic use of an antimicrobial to ensure that the wound didn't deteriorate again, even though the wound had become on a healing trajectory, because of their chaotic approach to the management of their wounds. Because we'd got the wound on a healing trajectory, it really needed prophylactic use to ensure that we kept on top of it. However, if you do assess your patient and do feel that they need this prophylactic use, always discuss it with your local wound care specialists, and in line with policy, and just make them aware of your concerns and why you think that it needs to use it. So obviously we've covered the importance of wound infection and the need to reduce antimicrobial stewardship. So what can you do yourselves to ensure that you're playing your part? So the government has developed a 5-year plan, and this was obviously it was put in by the previous government. However, they are continuing on with it. And that 5-year action plan is to reduce the need and the unintentional exposure of antimicrobials. Sorry, can't talk. So it's only using them when you need to. It's optimising the use of antimicrobials. The government are investing in innovation, supply and access, and they're being a good global partner. So they're sharing their successes, but also their fails with other people that are involved in the initiative, so that we can all learn from each other. But as clinicians, we can improve on our infection prevention management. So ensuring we're doing aseptic technique, making sure that we have our yearly sign-offs for aseptic technique as well, in line with the Royal Marsden Manual, or just adopting really good clean technique where we can't do full aseptic. We also want to be increasing clinician and public education on antimicrobial stewardship and antimicrobial resistance. So, like I said, challenge practice that you're seeing, challenge traditional practice and change that if it needs to. And we also want to be operating an antimicrobial stewardship, so appropriate education, appropriate duration and appropriate product. And following the 3-step approach can help that, because it gives you that simplified framework. It breaks it all down for you through that assessment, that preparation and treat. So it can take some of the burden away from everything else going on and breaking it down simply for you. After today's session, you'll get a copy of our antimicrobial stewardship pathway that will help you in your practice, and it gives you some clear guidelines of how to follow down the assess, prepare, treat and the steps that you need to do. And there's a product selection guide that will come alongside that, but obviously utilise whatever's on your local formulary. And that's the end of the session. Has anyone got any questions?
Well done, Kirsty. That was a lot of information that you have shared. Really, really good, really informative. And yeah, like I say, so much information to get through. There's been a few questions just asking about the slides. So after today's session, you'll get a copy of the recording. And I've just put in a link to an evaluation form. So if you can complete that evaluation form, and then you will get your certificate.